Okay, great. Well, then we're going to get going because it's 8:01. So good morning, everyone. We got Dr. Ted Wein from the University of McGill. He's an assistant professor there in neurology, and he works in the stroke prevention clinic at the Montreal General Hospital. He's got lots of interest in acute stroke care as well as secondary stroke prevention, and has a number of publications in this area. He is currently the co-chair of the Canadian Best Practice Stroke Prevention Guidelines and the chairman of the Spasticity Section for Canadian Botulinum Toxin Conference, and is on the steering committee of several ongoing trials that are looking at the effectiveness of botulinum toxin on post-stroke spasticity. I didn't even know that worked for that. Anyway, much as cardiologists know about botulinum. I think my brother uses that for migraine or something.
Yeah, very good.
There you go. So he's a fellow of the American Heart Association Stroke Council, serves on the board of directors of the Canadian Stroke Consortium, and is a well-known speaker, and is going to give us an update on stroke and what's going on in the COVID-19 era. And thanks, Ted, for agreeing to do this. I know we're all busy, but this is always good to have some of these updates in areas that we're not that familiar. So take it away. Just press your share screen thing there. If there are any questions, you can write to me on the chat and we'll get going.
All right, can you guys see these slides?
Yep.
All right, so thank you everybody. Thank you very much for that nice introduction. So what I'm going to talk about today is not entirely on stroke. There's three parts to my talk. The first part is to look at primary prevention and its impact on the use of aspirin and whether we should be doing that. We had, as part of the CCS and the Canadian Stroke Best Practices, as well as the Heart and Stroke Foundation, plan to have a new guideline on the use of aspirin for primary prevention. And lo and behold, I was the one who was put in charge of this guideline. So I'd like to go over the logic and rationale regarding this guideline, as well as why we're going to recommend mostly against the use of aspirin in primary prevention. So that's part one. Part two is to really review, because we've had so many questions on this concept of COVID-related stroke, to see what data is actually out there. This has made the front page of the New York Times and every newspaper and media outlet, and everybody's saying we're going to be swarmed with stroke-related COVID cases, just to show you where we stand on that. And then the last part of this is just to look at the Canadian Cardiovascular Society guidelines on use of antithrombotics or anticoagulants in the atrial fibrillation population and what we should consider doing in this COVID era. And then the last part after that, this is sponsored by Servier, is just a brief overview of some key points I think that we should consider in NOAC selection in individuals if we have time for that. So I'm going to go ahead and get started here. My disclosures are as follows. As you're aware, I am the chair of the Canadian Stroke Prevention Guidelines, both the secondary prevention and now the aspirin primary prevention guidelines. I have received support from just about every company and research grants from them as well. I am not here to recommend a product, but just look objectively at data here. And these are really the objectives for today, but I'm going to dive directly into the aspirin guidelines, which I think has a huge impact for cardiology as well as for individuals with diabetes. So what prompted us to go ahead and look at these guidelines, which we were supposed to present March 23rd, which was right smack dab in the middle of the COVID crisis as it just started. And I had interviews with CBC, CTV, television, who all canceled it because
Ted,
COVID was more interested.
Ted, it's Carlos.
Yeah.
You mind putting the presentation mode?
Yeah, absolutely.
Sorry.
Is that better?
Go. Yep.
Okay. So why did we go ahead with these guidelines and what was the need? Well, I think there were three major trials that were published in 2018, SPREE, ARRIVE, as well as ASCEND. And for this reason was one of these reasons, as well as three subsequent meta-analyses that prompted us to come out with a new guideline. And basically the three trials showed that there's little if any, benefit with aspirin in most populations, which was totally offset by the increased risk of serious bleeding in individuals with coronary artery disease, stroke, as well as vascular events. And this was subsequently confirmed with 3 subsequent meta-analyses, of which I'm going to go through because I think there's some really interesting points there. And as a result of that, Heart and Stroke led an extensive review of the literature, and we as a committee came up with new recommendations, which were released yesterday. What yesterday was March 23rd. And this comprised, if you look at the authors here, of cardiologists, neurologists, pharmacists, family practitioners. And the only thing we skipped and didn't do that we should have done in retrospect was to have an endocrinologist on the committee. So how many Canadians actually take aspirin? So before this publication, we conducted a nationwide survey through Heart and Stroke. This is published on their website. And basically, we have 5 million Canadians that are advised to take aspirin by health professionals, which is 17% of the Canadian population. We have 2.9 million people who actually listen to their healthcare professional and actually take the aspirin that's suggested to them. So around 58% of them actually do what they're told. But interestingly, we almost have 2.5 million Canadians who take aspirin for primary prevention on their own without the advice of anybody, think it's a healthy thing to do. So we have around 5.5 million people in Canada currently taking aspirin, and this is for primary prevention, not for secondary prevention, but for primary prevention. And when asked if they would take aspirin, even know that there was a bleeding risk, around 16% of respondents said, yeah, we would still take aspirin. And so the question is, what is the role of aspirin in primary prevention for stroke, cardiovascular disease, and what should we be doing? And particularly in the COVID crisis, when these articles of massive strokes happening in young people came out, there was a huge segment of the population that suddenly started consuming aspirin for primary prevention. So I think the timing of this is very good. So the new recommendation, I'm going to start off with secondary prevention, which is what the CMAJ advised us to do, was that secondary prevention, that aspirin is strongly recommended for secondary prevention in individuals with symptomatic cardiovascular, cerebrovascular, peripheral artery disease. So please don't start aspirin. You guys know that this does work in secondary prevention, evidence of level A. But our new recommendation for primary prevention is as follows, and I'm going to read it verbatim because we spent months arguing on the exact nomenclature here. So the use of aspirin is not recommended for primary prevention of a first vascular event, evidence level A. This recommendation pertains to individuals with vascular risk factors who have not had a vascular event, evidence level A, and for healthy older individuals without vascular risk factors, evidence of level B. The second point was that the net benefit of aspirin in individuals with asymptomatic atherosclerosis is uncertain. So there was no conclusion on what to do with the individuals with, let's say, in my field, a 50% carotid artery occlusion. Is there a benefit for aspirin there or not? There's conflicting results in the literature. And so we left that as a vagity here, leaving it to the discretion of the physician, should they find a clinical scenario where they deemed it necessary to prescribe ASA for primary prevention. We also have a new section now, which is recommended in all guidelines now, which is the concept of shared decision-making. Health professionals such as primary care or subspecialties, healthcare providers, nurses, nurse practitioners, pharmacists, and physician assistants should engage patients and caregivers in discussion regarding the use of aspirin for primary prevention of vascular disease. And it turns out in another Heart and Stroke survey that the pharmacists are the one who promote the use of aspirin the most of any healthcare provider. Finally, an individual's risk-benefit values and preferences should be considered in order to make an informed decision to initiate, continue, or discontinue aspirin for primary prevention of vascular disease. So as shared decision-making becomes part of the legal process for any medication that you should give, I think this case here highlights the need for shared informed decision-making on the use of aspirin for primary prevention. So I always like history, so I was interested in what the history of aspirin was, and it's a medicine made from the willow bark. And for those of you interested in ancient Mesopotamia or the ancient Egyptians, the clay tablets from Sumer and also the Ebers papyrus from ancient Egypt, they talk about boiling willow bark and using it as a herbal remedy, mostly for fevers as well as some myalgias. Hippocrates referred to the use of salicylic acid in tea to reduce fever around 400 BC, so a long-standing history of its use. And willow bark extract became recognized for its specific effects for fever, pain, inflammation, joint pains, myalgias in the mid-18th century. The person that really, well, this product was made popular in terms of aspirin by Bayer Pharmaceuticals in the early 1900s. The credit to creating sodium salicylate with acetyl chloride to produce acetylsalicylic acid really goes to a very interesting chemist named Charles Frederick Gerhardt, who in 1853 actually developed aspirin, or the initial version of aspirin, for the first time, and actually became extremely wealthy doing this. He was an incredible chemist. He was an adventurer, and he came up with all these different cocktails to try to test out new medications. The only problem with him is he didn't believe in animal studies, and he tested the medications on himself first, having such confidence in it, only to poison himself in 1857 and die from, I'm not sure what the concoction was, but you never heard of him because he poisoned himself and died from one of his creations, even though he should be credited with aspirin. When aspirin first came out, I just want to point out that Bayer said, hey, these are ads from 1920. If you notice on the bottom, their biggest statement was that this does not affect the heart. It came out as something for pains, fevers, chills, toothaches, etc. And that was, maybe we should go with our gut reaction on what it was first created for as to why we should or should not take aspirin. I want to point out that I love medicine because we're always changing our ways and we're always learning from what we do. And this product from Bayer, they actually had another product that we don't really use, which was heroin. So Bayer's initial products that made them a lot of money were the use of aspirin as well as heroin. And what we're going to try to push you for is saying we don't use heroin anymore for sedatives or coughs, or at least we don't use that where I live. But aspirin also is something that I want you guys to reconsider, perhaps using in a different fashion, clearly in secondary prevention, but I think we have to change our approach for primary prevention. So aspirin is one of the most widely used medications globally. Some 40,000 tons of it are used, and anywhere from 50 to 120 billion pills are consumed each year. And the World Health Organization lists it as an essential medicine. So a lot of consumption of it, and our entire point is there's a lot of people taking this on a regular basis for primary prevention. And the question is there benefit to this or not? So I'd like to go through each of the guidelines and give you, and I'm sorry if I bore you, but this was the rationale that we went through as a committee in order to establish the guideline that I gave you. And so the first is the ARRIVE trial, which is the use of aspirin to reduce risk of initial vascular events in patients with moderate risk of cardiovascular disease. And it was a double-blind placebo-controlled trial published in the Lancet, so high impact factor journal. And I think it's really important to look at who was included in these studies as we try to figure out who we should or should not give aspirin for primary prevention. So this study looked at men greater than 55 and women greater than 60, who in men had 2 to 4 risk factors and women had 3 or more risk factors. And those 2 to 4 risk factors included smoking, dyslipidemia, hypertension, and most importantly, that I think affects the cardiology community, is individuals with a history of coronary artery disease. They were never allowed to have had a vascular event, and they were randomized to 100 milligrams of aspirin or to placebo. So what were the results or the primary outcome? Well, the composite vascular endpoint in this study was cardiovascular death, myocardial infarction, unstable angina, stroke, or TIA. And they studied around 12,500 patients with a mean age of 64 years. They had a nice follow-up of around 5 years, and there was no benefit in the primary outcome or component. But what they did find was that it increased GI bleeding. In fact, there was twice as many GI bleeds. The absolute numbers I'll point out are small. It's 0.97 versus 0.46, but there was really no benefit. And to stress the no benefit, I'm just giving you this slide here where you see on the top left as you look at your screen, the primary outcome showing no difference between placebo and aspirin. If you look at the MI or stroke on the right, again, no significant difference. The MI in the middle bar, no difference. The stroke, clearly no benefit. These lines almost overlap. Cardiovascular death on the bottom left, you can see absolutely no difference. But you do see an increased incidence of GI bleeding that really starts at around a year and has a p-value of 0.006. So strongly positive for harm, but not really very supportive for a benefit to individuals. The next study was the ESPRIT trial. So this was the effect of aspirin on cardiovascular events and bleeding in healthy elderly patients, and we'll define elderly. I'm not here to offend anybody, and this, of course, was published in the New England Journal of Medicine. So this study looked at African American or Hispanic men who were over the age of 64 years of age, and Caucasians who were a little bit older and had no history of vascular events and were randomized to either aspirin 100 milligrams or placebo. So similar to the others trial, slightly different population, a little more ethnocentric. So the primary outcome in this study was a composite vascular event of either major hemorrhage and cardiovascular disease, defined as coronary heart disease, non-fatal MI, fatal or non-fatal stroke, or hospitalized for heart failure. And it had it had 19,000 patients with a mean age of 74, so an older population in this study. And they followed patients for almost 5 years. And if you look off to the right, you can see that there's really no difference in the composite vascular endpoint here. There was no reduction in the primary outcome, but again, for the second time now, we have a 38% increase in hemorrhagic rates. The absolute values, again, are low, but very similar to the prior trial. The final study, which throwed a little kink into our presentation, and I think warrants further discussion, was this study, the ASCEND trial, looking at the effect of aspirin for primary prevention, now in individuals with diabetes mellitus. And again, here we included men and women age 39 or greater with type 1 or type 2 diabetes. They had no history of vascular events, and they were randomized to aspirin 100 milligrams or to placebo. So this study is a little bit different because there was a positive outcome here. Their primary outcome measure was a composite vascular event rate that was determined by MI, stroke or TIA again, death from any vascular cause, and they excluded intracranial hemorrhages from this study, which is another point to take into consideration, and I'll show you why in a subsequent meta-analysis, because the ICH rates are increased, and I will go through that literature shortly. Large trial, 15,000 people, and nice follow-up of 7.5 years. Primary outcome was almost an absolute difference of 1.1%, but it translated only to a 12% relative risk reduction. And the risk of major bleeding here was an increase by 29%. So while you reduced the vascular event rate by 12%, the risk of major bleeding was increased by 29%. So what was the conclusion of these authors? Oops, I'm sorry. Before I rush to that, I'm sorry. Here you can see the graphs from the study. You can see with time that there was some benefit, and that was a 12% relative risk reduction on the top. But I'd like to direct your attention to the bottom, or graph B, which is first serious vascular event according to year of follow-up. And you can clearly see aspirin better to the left or placebo better to the right. And I just want to point out that aspirin actually did really good. It had a 26% relative risk reduction in those first 3 years. But as you got to year 3 to 5, that fell to a non-significant 15%. And after 5 years of long-term aspirin use, you clearly lose any benefit there, with placebo being greater. So as we look at use for long-term primary prevention, I would say over 3 years, there's no point. If there's a reason to put aspirin on for less than 3 years in this study, they did seem to have a benefit, although you need to address the bleeding rate. So what were the authors' conclusions for this study? Well, aspirin use prevented serious vascular events in persons who had diabetes and no evidence of cardiovascular events at trial entry, but it also caused major bleeding events. And their conclusion was that the absolute benefits were largely counterbalanced by the bleeding hazard rate here. So that was the conclusion from those authors. So those were the 3 trials that led us to say, hey, aspirin really shouldn't be used. You can argue that perhaps there's a role for its use in diabetes, but what's the risk-harm benefit? And I think one way to address that was to go to 3 subsequent meta-analyses that were done in 2019 to address various issues of the benefit or the pros and cons of aspirin in primary prevention. So you guys may not be familiar with this article because it was written in a neurology journal in JAMA Neurology. It was conducted or led by Jeff Saver, who you may know from the PFO closure trials, as well as Bruce Obivigiali, who's in San Francisco, and Ming Li, who's an up-and-coming star in the stroke field. So they looked at the frequency of intracranial hemorrhage with low-dose aspirin in individuals without symptomatic cardiovascular disease. So over the years, we've always suspected that aspirin may increase the risk of intracerebral hemorrhage, but in the studies done from the 80s mostly and early 90s, the p-value always came out just missed significance. So it was almost significant. It was like 1.04. And so they decided to look at, with all this new data and all these new preventative therapies and a changing population and changing ethnicity in the populations looked at, what happens to intracranial hemorrhage. So they looked at 13 randomized controlled trials of 134,000 patients. And it was primary prevention, the ages between 43 and 74. And their primary outcome measure was to look at, does aspirin cause harm and increase the risk of intracerebral hemorrhage? Their results, very clearly, low-dose aspirin compared to control increased the risk of any intracranial bleed. And in fact, it increased the risk in 8 of the trials by 37%, which translated to 2 additional intracranial bleeds for every 1,000 people. If you bleed in your brain, you have a 50% mortality. If you have an ischemic stroke, you have a 15% mortality. And so the greatest risk was not actually in intracerebral hemorrhages. It was actually more in subdural or extradural hemorrhages with a 50% increase in those spontaneous bleeds outside of the brain. So that's somewhat reassuring in terms of fatalities that we would cause. If we look here in part A, which is the first part of this graph, you can see that there's a 37% increase in any intracranial hemorrhage. If we want to look at the hemorrhages that I'm more concerned about, or bleeds directly in the brain, or intracerebral hemorrhages, you can see that there was a 23% relative risk increase that was not significant. So it did not meet values, but I want to point out that the p-value here is at 0.98 on the bottom end, if you can see it. Really, really close that this may increase intracerebral hemorrhage, but just missed it barely. So as you can see here, the biggest risk when you put people on aspirin is causing bleeding outside the brain in the subdural or extradural space, and that's a 53% increase. There is no increase in subarachnoid hemorrhage in this population. But what they did find were 2 other interesting groups, and depending on where you live, this is a completely useless piece of information or a very useful piece of information. But if you were Asian, you actually had an 84% increased risk of having an intracranial hemorrhage. So a little bit of a concern there. If you looked at non-Asians, a 14% non-significant increase. So clearly Asians who are more likely to have hypertension, more likely to have intracranial atherosclerosis, really seem to have an increased risk of bleeding intracranially. So a population, maybe you would think twice if they're diabetic if you're considering or entertaining putting them on ASA. Another group were individuals with BMIs. And this time, if your BMIs were greater than 25, you didn't really have an increased risk. But for individuals with BMIs less than 25, and again, an Asian population here, you had an almost identical risk of 84% increase in the risk of intracranial hemorrhage. So a lot of data supporting increased risk of bleeding, not only major bleeds, but if you recall the last trial looking at the diabetic population, that they excluded intracranial hemorrhage as an outcome measure when it is elevated in individuals taking aspirin in primary prevention. The author's conclusion in 2019 was that the use of low-dose aspirin for primary prevention of cardiovascular events in individuals without symptomatic cardiovascular disease was associated with an increased risk of overall intracranial hemorrhage. They said, hey, we should pay particular attention to individuals who are of Asian descent or in populations with low BMIs, although all the BMIs are only in the Asian population in their meta-analysis. But their conclusion was as follows, that because the benefits of low-dose aspirin for primary prevention is not well established, the outcomes of intracranial harm with the outcomes associated when you bleed in your brain, as I mentioned to before, can carry a mortality of up to 50%, and that these findings suggest caution when regarding low-dose aspirin in individuals without symptomatic cardiovascular disease. So as you go ahead to put individuals on ASA for primary vascular protection, you got to realize that major bleeds are elevated, and bleeding in the brain, which is potentially life-threatening, is also elevated as well. The second meta-analysis I'd like to review with you guys is the study by Mahmoud and colleagues. And so they looked at safety and aspirin for primary prevention of cardiovascular events, and they had a meta-analysis of sequential randomized trials that they looked at. And so again, published in 2019, one of the 3 trials published. And what did they found? Well, they looked at 11 randomized controlled trials, so away from the neurology bent now and going to the cardiovascular disease. And they even looked at individuals with known atherosclerotic disease in this meta-analysis. The primary efficacy outcome was all-cause mortality, and they looked at primary safety outcome as major bleeding, and mean follow-up time in their study was around 6.5 years. So what did they find? First of all, aspirin was not associated with a lower incidence of all-cause mortality in individuals with asymptomatic atherosclerosis. The relative risk reduction was 2%, so clearly no benefit at all there. Aspirin was associated, however, with an increased incidence of major bleeding. Again, this recurrent theme of increased major bleeds, 47% in this meta-analysis. And like the prior trial presented by Jeff Saver's group, aspirin was associated with an increased incidence of intracranial hemorrhages, also by around 33%. So it's clearly a second trial now showing increased bleeding in the brain anywhere from 30 to 37%. And as I mentioned before, Asians up to 84% on individuals with small BMIs. If you want to look at all the studies to see if there's any trend or inkling that there was any benefit, and the summary plot for primary efficacy, you can see on top that there's really no benefit at all. If you look at major bleeding, numerous trials, everything shifted to the right, saying that aspirin is associated with a worse outcome for our patients. If you want to look at the other groups that we routinely look at, you see no benefit in diabetics. If you look at different dosages of aspirin, which is varied in the trials, but doesn't go up to mega doses, less than 100 and more than 100, perhaps the higher dose may have an advantage there, but it didn't pan out statistically. And if you look at the number of people there, it's 12,000 patients versus 65,000 patients in the less than 100 milligram group, although perhaps that's another group we should explore a little bit. Depending on when the patients were enrolled in trials, there were different healthcare practices before 2000 and after the year 2000. If you look at MACE risk, there's no difference there, and bias in terms of entry into the trial didn't show anything. What it did show, however, was a little blip of hope for you guys in cardiology, where there was an 18% benefit in reducing the risk of MI. But that was offset by a 47% increase in major bleed or in intracranial hemorrhage. So there is some rationale to say, hey, we can prevent MI a little bit, but we pay a vascular risk price for that, as you can see underneath. The author's conclusions were aspirin use among healthy individuals with known atherosclerosis appear to be associated with increased harm and lack of mortality benefit. The only subgroup that seemed to have some benefit was the MI population. In this setting, aspirin is possibly associated with moderate reduction in MI. However, it comes at a cost of increased major bleeding and ICH. And the routine use of aspirin for primary prevention needs to be reconsidered, was the conclusion of these authors. The final study is a meta-analysis published in JAMA at the end of 2019, and this was the association of aspirin use for primary prevention with cardiovascular events and bleeding events, and they did a review in their own meta-analysis by Zhang and colleagues. So they looked at 13 randomized controlled trials, 165,000 patients were looked at, over 1 million participant years, and they had a good chunk of patients who were diabetic, another high-risk population. And their outcome measure that they wanted to explore was primary cardiovascular outcome with a composite endpoint of cardiovascular mortality, non-fatal MI, and non-fatal stroke. So what did they find? So they did find some benefit here again, which is why we left that other aspect to our guideline, giving physicians the option in that second choice. But here, aspirin use was associated with reduction in the composite cardiovascular outpoint. So we had around 11% relative risk reduction, an absolute risk reduction of only 0.41%. If you look at 60 per 100,000 participant years with aspirin versus 65.2, number needed to treat here is 241. But aspirin use, again, clearly a recurrent theme in all of these studies and meta-analyses is aspirin use seems to be associated with the increased risk of major bleeding events compared with no aspirin, 23 per 10,000 versus 16.4 per 10,000 patient participant years. Hazard ratio here of 43% increase, an absolute risk increase of 47%, 0.47%. So the number needed to harm here is 210. So for every 241 patients we treat, we're going to have at least 1 point something bleeds that we're going to provoke as a result of that. Could we find anything in subgroup analysis? So again, composite cardiovascular outcome endpoint positive by 11%. You can see ischemic stroke reduction in there with a reduction of around 19%, MI decreased by around 15%, cardiovascular mortality not significant, all-cause mortality not significant. But the number needed to treat for MI is 361. Number needed to treat for ischemic stroke, I put there on the bottom, I'm sorry it's not labeled more clearly, is 540, but this comes at a number needed to harm of 210. So at least for stroke prevention, you're going to cause 2.25 major bleeds for every stroke that you can prevent. And for MI, for every 1 MI we prevent, we will cause 1.5 major bleeds. Again, the duration of ASA exposure has a strong influence in this, but if you look again in their meta-analysis, major bleeding increased by 43%, intracranial bleeding in their study increased by 34%, and major GI bleeding increased by 56%. So again, count for everything you do, you seem to be counterbalanced by increasing the risk of bleeding, having a null effect in the end. So the author's conclusion was that the use of aspirin in individuals without cardiovascular disease was associated with a lower risk of cardiovascular events and an increased risk of major bleeding. And this information may inform discussion with patients, again, where they're promoting what we've put into our guidelines, shared decision making about aspirin for primary prevention of cardiovascular events, as well as bleeding. So there's still a lot of challenges and gaps in knowledge here that we couldn't really address in guidelines. The BMI, again, remains a problem. I didn't discuss it here, but gender in some of these studies has differences between men and women. What do we do, or what's the risk with the AFib population? Has only been partially studied. Individuals with asymptomatic carotid atherosclerosis. As a neurologist, what do I do with the individual with small vessel disease on MRI? What do we do with the so-called asymptomatic vascular disease? We have one analysis showing no benefit. We have a study with carotid atherosclerotic disease from the ACAS, or the asymptomatic carotid artery stenosis trial, showing no benefit. But there is one study done by David Spence where they suggested that there is some mild benefit, but no large randomized trials and some conflicting data. And this is really the zone where I think there's going to be shared decision making, and physicians may want to not follow the guideline, of which we've given them the out in the guideline by saying that there is unclear data for individuals with asymptomatic atherosclerotic disease. So after 4 months of haggling and arguing, we actually brought together the CCS sat at this roundtable, Thrombosis Canada sat at this table, the Canadian Stroke Consortium, the Association of Pharmacists and Hospital Pharmacists, which are apparently 2 separate unions I found out, as well as nurse practitioners sat around, but this guideline is endorsed by everyone you see in this window here, and appears on all of their websites in full support of this. And so I think this was a long time in coming, but I think it was clearly necessary because the risk-benefit ratio really needs to be reevaluated in some patients. The other big gap that we don't know what to do is what happens in individuals who've been on ASA for primary prevention Do we stop it? Is there a rebound effect from their aspirin or not? And that's another dilemma that this guideline leaves you with no clear-cut answer from what we see here. So I want to switch gears a little bit and talk about COVID and neurological complications as well as stroke. Um, when COVID first came out, nobody really knew what to expect. I've been blessed in Montreal. Our Montreal Canadiens haven't won since 1993, but finally we're #1 in COVID cases in Canada, and until Brazil recently, we were ranked #3 in the world for cases per 100,000 people. So we've had a very interesting and hard time here, but I just want to share some of the neurological manifestations quickly with you guys, and then just briefly present some of the data on stroke, which I hope you're a little bit interested in, but I'm not sure I have a lot to present to you, but sort of to allay the fears of this massive thrombotic events in all COVID patients that will be causing strokes, because that's not really what we have seen. We've had no COVID-related strokes that we've actually confirmed since this has happened despite being so hard hit, but I'm going to go through the data that brought this to the media. So this is one of the first articles published on neurological complications of COVID-19. There's many that are published online and never get peer-reviewed and seem to disappear. But it seems like almost 1/3 of patients with COVID-19 will present with some neurological manifestation. While the most common ones are just dizziness and headache, which accounts for more of them, around 10% of them present with impaired consciousness, with cerebrovascular disease accounting for around 3% of initial presenting symptoms of COVID. But there's other things that you're aware of that's changed over time, such as taste, smell, vision. There's been increased incidence of Guillain-Barré syndrome in patients, but again, the numbers per 100,000 are relatively low. And so it is there. It seems to enter orally, but also probably through your nasopharynx and through your olfactory nerve, which gives people their loss of taste to cause some of these symptoms. But 1 in 3 patients is going to have some neurological manifestation of COVID-19, and one of the hypotheses of the diarrhea that presents with COVID, which unfortunately happened to one of our residents here, is of an autonomic dysfunction as well. If we look at who gets neurological symptoms, is it the mild cases, the severe or not severe cases? It really seems individuals with more severe CNS symptoms have lower lymphocyte counts. They tend to have slightly lower platelet counts. I'm not sure this is directly related. I didn't show you, but they tend to have higher CRPs, which is sort of cut off in that second box right under it in the middle. You'll see the mean CRP for a neurological manifestation is at 48.6, so a little bit elevated. No significant change in D-dimer in this population. Slightly elevated CKs. The transaminitis that we see not really significantly present, but blood urea nitrogen tends to be a little bit higher in the severe cases than the non-severe cases. So just a metabolic profile of what may predict neurological involvement. So I'm just going to present this one study not talking about vascular disease because it was interesting and it was published in the New England Journal of Medicine. A lot of the studies in neurology are being retracted now for poor data, etc. But this was a French ICU study looking at 58 consecutive patients. 14% presented with with neurological symptoms at admission. But I want to point out that 3/4 of them, when taken off of sedation, had neurological symptoms. While agitation may be the biggest thing, I think the most concerning thing is the cognitive delay a lot of these patients complain of. In fact, 1 in 3 patients that left the ICU here had major problems with cognition, mostly with executive function. So that's inattention or disorientation, but really how to follow multi-step commands. And it's something we've seen here a lot in our patients, is that there's clearly some CNS infiltration of SARS-CoV-19 that gives you some real cognitive retardation and carrying out executive function and being able to function. With patients now 3 months post-COVID, still calling and complaining that their cognitive status is not there. During the ICU admission here, 67% of people had Babinski's, or some clonus or tone. So there's clearly some diffuse systematic effect from this virus that affects the CNS in a non-specific way in the majority of our patients. But really this cognitive or executive delay is something that we see that at least now, 3 months afterwards, I have patients continuously complaining of this, and we're really not sure what to tell them. Will it go away spontaneously or not? So let's look at some of the stroke cases that were provided, or some of the data on stroke cases that are out there. This is from Mao and JAMA Neurology, and in another series. I just put it together to give us a general idea of what's going on, because as you're aware, there's a study which I'll present to you shortly from New York that reported in a 10-day period, one New York hospital at Mount Sinai Hospital, Tom Oxley reported 5 people with large vessel occlusions. And if you guys watch 60 Minutes, they featured the Northwell healthcare system in Long Island, where my cousin happens to be the chair of neurology and head of the stroke program there. Well, they've had massive amounts of multi-vessel strokes, and really that New York area seems to be hit with this large vessel occlusion. And we here at McGill were preparing for this, expecting multiple strokes to occur. Fortunately, 3 months later, and at the end of this current wave, that has not appeared at all. I want to point out that it was been reported in one study in 5% cases, but 39% are diabetics, 54% have hypertension or some sort of glucose intolerance. But if you look at a series of 12 patients, and there's no large series here, so don't expect anything fancy, it was a third large vessel disease, which is a little bit higher than the norm. 28% small vessel disease, which is more or less in the norm, and 28% being cardioembolic, which is a little higher than the norm, and you can get a cardiomyopathy. There are several studies going on in Canada, based in Western Ontario, that you in Calgary are participating in, and I'm on the steering committee for, to look at the impact of COVID on type of strokes. And so we'll have more data on that, although our numbers to contribute to the study are pretty minimal, if not zero. So this was the big study presented in a correspondence only. So a little letter or a small correspondence made the front page of the New York Times, CNN, and all major networks that everyone's going to die of COVID and have strokes before they die. Unfortunately, or fortunately, there's only 5 cases in this series from them. What was interesting about the series is the age of these patients. They all were between age 33 and 49. Only one of them presented with real COVID-like symptoms at the beginning, but their initial presentation was of a vascular event. So patient 1 had cough, headaches, chills, and patient 5 had fever, cough, and lethargy. But the other patients, 2 of them really didn't have anything, and 1 patient was just sort of a little bit lethargic, but didn't have any major symptoms. If you look if they had any major vascular risk factors, the answer was not really. 1 had hypertension, I think 1 was diabetic, but the scary thing for all of this was that they all presented with large vessel artery occlusions. 3 of the 5 had D-dimers that were, or 2 of the 5 had D-dimers that were high, 13,000 and 2,230, and then they dropped down to 1750 and 460. So elevated D-dimers was a big factor in some of these people, but for most of them, they didn't really find any other etiology to the person's stroke and attribute it to this hypercoagulable state from COVID-19. But outside of those 5 patients, those are the only case report to date in the COVID-19 era to suggest that younger people may be at risk for stroke. I have contacted my fellow colleagues and former fellows at the University of Texas, University of Miami, University of Pennsylvania, Boston group, as well as University of Michigan and Cincinnati, which are my best friends who live there, and none of them have seen any of this either. So more of a New York-based phenomena, but we'll see as there's NIH-funded trials to look at the impact of COVID and stroke and a Canadian trial. But right now, outside of this study, which was a letter, not even a study, we don't have any other significant data here. There's a study that I found online that is not peer-reviewed where they had 5 men, 1 woman. All of them had a transaminitis, which they attributed as a predictor of their stroke. 2/3 of them had elevated D-dimers with decreased platelet counts, but an increased PTT. At the time of the publication, they didn't even wait till the end to see what happened to these people. 2/3 of them died. It's an Italian study, 1 in coma, 1 in vegetative state. What was interesting, if you look at some of these pictures, is that some of them had multiple baby strokes. The one picture on the bottom, this person had multiple bleeds in the brain from a coagulopathy. If you look at image G on the bottom in the middle, this person has 4 bleeds, 1 massive bleed and 3 smaller bleeds. These people did not have endocarditis, but just COVID-19. And if you look at the top image on the right, this person, I don't know if you guys can see my mouse, has an anterior cerebral artery stroke here, has a posterior cerebral artery stroke on the other side, and has another event over here. So multi-vessel strokes was also another concern in this small trial, which goes along with what they saw in New York, but not really what we're seeing anywhere else. If you looked at mortality from this, if you had a stroke and you had COVID, you were much more likely to die, 2.5 times the mortality. The severity of your COVID based on respiratory status also predicted your risk of having increased mortality, and having it with a stroke, whoopsie, and having it with your stroke also increased mortality by around 88%. And this other article that's actually peer-reviewed in Cerebrovascular Disease, I want to point out that they have 3 trials that they published. It's really a review of the American trial I showed you and the Chinese trial. They do add a Singapore trial to it, which is the last group on the far right. Previous heart disease, non-existent in any of these patients. Previous stroke, non-existent. Again, they come back with people didn't present with their COVID-like symptoms until 19 days after admission in the Singapore studies. And 4 of their patients were actually on a ventilator. 3 of them died. But again, no real data out here. But again, the recurring theme that we see in a lot of these stroke patients is that the COVID symptoms are things that appeared a little bit later or were diagnosed a couple of days after admission or at admission, but none of them really presenting with significant stroke with COVID symptoms prior to their event, usually just after the event. So another interesting aspect. This was just published last night online, and this is just a case report of everything that's out there. So I just want to point out that we only have 6 studies that have been presented out there. All of them suggest COVID and stroke increase your mortality to around 5%, anywhere from 2 to 5% that we see, but they report ischemic strokes, large vessel occlusions, small vessel occlusions, hemorrhages, and coagulopathies that all of these people get. So I'm not sure, Carlos, what you want to do now. Should I just stop here? There's 12 minutes, or should I go through this last section quickly?
Well, let's go through this last section and then leave a few 5 minutes or so for questions.
Perfect. So I've been part on 2 task forces, both here and in the US, and the concept is of having to ensure treatment of patients. Just because COVID-19 has closed many clinics does not mean we shouldn't not follow our patients. So there are 2 publications that I've been involved in, the Canadian Journal of Neurological Science, one looking at post-stroke rehab, the other one, a general one with cardiology from heart and stroke, mandating that you follow your patients and do as much as you can through via telemedicine, and to continue all aspects of patient care. There's also some tips from the CCS and Thrombosis Canada, which are worthwhile going, particularly in the concept of anticoagulation. Again, with warfarin, you have to come in for your INR. So for patients who are on warfarin and could be on a DOAC, probably a little bit safer for them to not have to go for the monthly blood test or whatever their serologies are needed in order to establish what's going on. I think another point to remember, and be interesting to do a national study, is don't forget to check renal function on patients, and remember to only use DOAC when appropriate, not indicated for mechanical valves. But the general concept here is, if you can avoid patients having to go in for additional tests, choose a medication that will minimize that, and that's from the CCS. Initiation of anticoagulation, you're all familiar with, but again, a little bit easier to initiate NOAC or DOAC instead of warfarin. For patients who are not DOACs, they also recommended on the bottom of this to consider the need for low molecular weight heparin as a possibility of something different to do. Should warfarin just not be practical in this COVID-19 era to follow patients and not having anticoagulation clinics or access to INRs, patient access to INRs, to consider doing something different until things open up and are a little bit safer for our patients. Please excuse me, I'm just trying to rush through this. Initiation of oral anticoagulation. They have an entire directive of this, and local pharmacies have been involved and contacted to this. And they're actually, I've had several pharmacies call me whether we can consider changing the warfarin to a DOAC. I told them no because it wasn't appropriate, but it's good to see that the message has gotten out there to different patients. Patients already on anticoagulation, I think there's something, is anticoagulation still required? For the most part for PAF patients, the answer is yes. Use telehealth visits, video or telephone visits, but really stay in touch is what Thrombosis Canada is saying. And they actually have specific questions to inquire about bleeding risk and checking for adherence to medications. And again, as I mentioned before, let's try to avoid repeating labs if it's not necessary. Minor bleeding issues can be addressed at home. These are 4 websites that I have for my patients, as well as for our nurse in the clinic, as well as for colleagues and family doctors. They're really, really helpful, and I'm more than happy to send you a copy if you're not aware of these sites, as simple things to have for your patients to access. And we actually have this in our clinic, that patients get a handout when they have bleeding at odd hours and are not sure what to do. There's also the University of Michigan that has some information on this. I'm not going to review on how to switch from a VK to a DOAC because I assume you know all of that. I just want to point out also that Thrombosis Canada has a checklist for clinicians that you can use should you deem it necessary, or should you have a nurse, medical student, or resident that's calling, that this is available at the Thrombosis Canada website to ask your patients. And here, with medical students not being in class, we actually have medical students using this to follow up on our COVID patients, as well as the previous questionnaire, in order to get them more involved in healthcare, but also to free us up to work in the hospital. Just for your knowledge, 1/3 of healthcare professionals in my hospital have become COVID positive. So we've been rearranging our times, and as you can see, I'm in scrubs for the first time in many years to do various tasks that we haven't done, and that's part of the reason we came up with some of these checklists as well. Michigan has a frequency of renal monitoring form that's out there that I consider you guys to address or assess also. So I just want to go through a couple of points in 3 minutes, and I'll speed through this because I want to leave a little bit of time for questions. But some pet peeves I have. So if you miss a dose of a twice-a-day NOAC, are you more protected than if you miss the dose of a once-a-day NOAC? The answer to that is we don't have any great objective evidence for that. One is once-day NOACs are a little bit more adherent than twice dailies. But if you look at, in this study done by Mark Albers, who's a neurologist who looked at a database of some 17,000 patients in the US, if you look at what happened in your stroke risk with all of this, if you missed your once a day or twice a day, the hazard ratios of having an event were almost similar. So as people say, you're more protected on the twice a day and the once a day, at least in the literature to date, we don't have any evidence of this. We do have some pharmacokinetic data to suggest that missing the once a day may be bad, but I've not seen that translate into any clinical event rates. Please, you guys all know all of this, but please follow the product monograph. Inappropriate dosing of a NOAC increases the stroke risk of the patients. So what happens when we inappropriately underdose? There was a nice study published in Stroke by Mike Pacciaroni. This was an international study doing 713 consecutive patients who had strokes while on their NOACs. And when they looked at the hazard ratio of taking appropriate versus inappropriate dose NOAC, you were 3 times the risk of the stroke. So please follow the monograph verbatim. Don't make clinical decisions on your own, because it seems that if you don't follow the recipe from the monograph, you're at higher risk for stroke. this is an interesting study, just saying what patients preferred in terms of NOACs. They prefer once a day, smaller capsules, don't have to take it with food, and they also don't want to drive more than 16 kilometers to the pharmacy to get their pills, they say. So I'm going to skip that. And the last point is just a bullet point on the NOAC safety in the elderly. If we look at all the studies out there, we have around 10,000 patients over 80. We have around 2,500 patients for those over 85. I'd say the biggest cohort is in the ENGAGE-AF trial with the edoxaban, although it's only 899 patients. Aristotle only has 322 patients there. And we have around the majority of the data coming from ENGAGE and RELY, with Rocket having the least amount of data on those older patients. Our mean age for stroke here at McGill is 82 at the university, community hospitals 88. So we see a lot of these older patients. It's interesting as we look at Rocket AF, the benefit seems to shift to favors warfarin a little bit, but I'd point out here on the bottom, Aristotle greater than 80 maintains its benefits. Small numbers for the greater than 85, non-significant trend, but I'm sure it's a number problem. And that ENGAGE AF has a nice series of data published on the use of NOAC in the older population. And this is just in terms of efficacy doesn't change either. I'm sorry, this was major bleeds in the prior trial slide. So I just want to thank you and hope you guys are well. You've been very fortunate that you haven't had the COVID crisis we have, but I'm more than happy to address any questions you have at this time. Thank you.
Thanks, Ted. That was great. I don't know if there's any questions there. So let me ask you something. You know, there's a lot of people out there that take aspirin like every other day and not necessarily on a daily basis. So should we just tell them, you know, stop that and don't fuck around with that?
Yeah, so I mean, we had a big debate and we didn't really know how to address that. So for the majority of us, we'd say we'd all tell them to stop aspirin if not indicated for primary prevention. But you know, as raised in our discussions, the big question was like, do you develop will you get some rebound effect from stopping the aspirin? And if we looked at antiplatelet sensation prior to surgical procedures, you know, the risk of stroke or MI stopping an ASA for a secondary prevention patient is around 2.5%. So there is some risk to the patient that's there, but the majority of us, and there's 16 of us that sat on the board, and 15 of us said they would absolutely stop aspirin if not indicated now with no problem and not worry about that. One other person said they would have a lengthy discussion with their patient and this warn them of, we don't know what happens when you stop it after taking it for a lengthy period of time. But it's really interesting that I would suggest to stop it. But as we look at the major bleeds and everything, and I don't know about you guys, you know, I have thousands of patients I put on aspirin, always in secondary prevention. I've never seen the GI bleeds and stuff like that. We have seen a lot of intracerebral hemorrhages on aspirin spontaneously in the elderly. So the cause and effect are not there. But to answer your question is, I would tell them to stop it, is based on our guideline, and I stand by what I wrote.
So what about because there doesn't seem to be a lot of guidance on, you know, we do more and more imaging on these patients, like for example, CT angio. And,
Yeah.
you know, the guy comes in with a calcium score of 100 or over 100,
Yeah.
which we know that carries a risk of events that is incremental. Would you give aspirin to someone like that? He's asymptomatic.
Yeah, so the answer is I would not give them aspirin based on the guideline. If you look at the meta-analysis by Mahmoud and colleagues of 154,000 patients, they found absolutely no benefit and a 37% increase in intracerebral hemorrhage rates, and their number needed to harm was 210.
Yeah, but no benefit in mortality, but there was benefit in MI.
Right, so there was
and you know, intracerebral hemorrhage, like, you know, it's an absolute risk increase of less than 1%.
So I agree, but if you look at the absolute benefit on preventing an MI in that group, it was 0.47%. So both numbers are low and sort of negate each other with no net benefit. In the guideline, because of your very valid point that you just wrote out, if you look at the second point of that guideline, it says that the individuals with asymptomatic atherosclerotic disease is unclear, and we give it level B, and that's exactly what we've given individuals, physicians, that we've given individuals the the choice to decide what they want to do in that scenario. And that's exactly why we put that on. For those of you that read CMAJ, I have a podcast with Andreas exactly on that clinical scenario that's there. And you will see a letter in CMAJ coming out on in 2 weeks or 3 weeks from David Spence saying, hey, individuals with asymptomatic atherosclerotic disease do benefit and we should treat them, because he has a study that showed that asymptomatic carotid artery disease responded to the aspirin. So that's where we have the two pieces there. One was the outlet to give the physician the option with that second point of the guideline. And secondly was this whole new aspect of shared decision-making and discussing it with the patients. The number of individuals I see with asymptomatic carotid disease is only a fraction because we don't do ultrasounds of all of these people. And with your calcium indices, it's there. So there's clearly a benefit.
So what about, let me ask you, so let's say that many of these patients would be like COMPASS trial criteria.
Yeah.
So would you give them the low dose rivaroxaban plus aspirin?
Yeah, absolutely. I think you can follow the COMPASS trial, and I think that would be a great avenue for them. The problem with COMPASS is we don't have long-term follow-up, and I'd point out from the same Mahmoud paper that there was a benefit in individuals less than 3 years. There was a clear-cut 26% reduction in MI and cardiovascular events. And the question really is, should we be treating these people for 3 years is when their benefit is, and then after that it goes away? You know, COMPASS also had an increased risk of bleeding in that study that people will still argue. And I think
it's a 70% increase in bleeding, but again, that's misleading because, you know, the absolute risk went from 2 to 3%. So it's a 1% absolute risk in bleeding. So again,
no, I totally agree with you. And the absolute rates of bleeding that I presented here are in the 0.47%.
Exactly.
And so they're all really, really low. So it's really a risk benefit ratio. And I think this asymptomatic atherosclerotic group is the biggest group. And I said that in the presentation, that really needs to be explored more. We have COMPASS, which has had mixed reviews, at least, how should I say that? As a neurologist, when I first wanted to put out a guideline for the COMPASS data, we were told from Heart and Stroke, let's see what CCS and cardiology is going to do. And if we look at the delay from comments from COMPASS's publication or the data being presented and how it's been incorporated, I do not see a lot of people on COMPASS dosages coming into my ER, maybe because they're all being prevented, but I am not sure what your group.
You know, it had a huge benefit on stroke. You know, it was 42% relative risk reduction on stroke.
So absolutely, and the stroke community, unfortunately, when we brought it up in our guidelines, I think there's two problems. One is that it's a new concept for people, so they're not really sure what to say or do with it. Two, it's a trial in isolation, and it's good to think outside of the box. And I think, you know, physicians say think and do no harm, and I think that's where we're really stuck right now. I mean, you can argue with all our guidelines. These absolute bleeding rates are low. There's a potential for benefit. There's clearly some populations that are at higher risk, but I don't think we have a home run that aspirin's a clear-cut winner for a lot of people.
So just to make it clear, so someone with incidentally diagnosed CAD has a positive perfusion study, but no prior ACS or stroke, you do not recommend aspirin?
Well, if they have a positive perfusion study, I'm not sure you're going to call them asymptomatic at that point. Is that fair?
I know
that's the gray zone. So thank God I'm a neurologist and I can say refer to you.
Sent to the cardiologist. Well, I'm an electrophysiologist, so what do I know? AFib.
Yeah, but I'll translate to neurology terms. If I have somebody who has microvascular disease in the brain, I consider that symptomatic and I will put them on aspirin. And so those people I will treat. Individuals with
I don't know. I would argue that, you know, I would prefer to just knock down the cholesterol as much as I can, and then that would be probably better.
Yeah. So
maybe even giving colchicine instead of aspirin.
Yeah. So I would say, contrary to that, I think the biggest predictor of small vessel disease in the brain is actually hypertension. And the biggest reason to do that is it would be to lower blood pressure. But I think that's one reason why we've had such a skew in events right now is there's these newer studies in a new generation after 2000 where the use of statins and antiplatelets are so prevalent, I think it's really detracted from the benefit of this antiplatelet, which I don't think I think there's a role for it, but at least in my profession as a neurologist, aspirin is the least beneficial therapy of anything. You lower blood pressure by 10 millimeters, you have a 33% reduction. You lower your LDL by 50%, you get a 30% reduction, and aspirin only carries a 13% relative risk reduction for us. So not a clear-cut home run. And again, the biggest next step is to explore this asymptomatic atherosclerotic group to see is there or is there not a role for it. We don't have the benefit that you guys saw with your PCSK9 inhibitors of decreasing stroke risk in individuals, unfortunately. So we look for alternative therapies, but from a cardiology perspective, you know, again, what do you do with that asymptomatic, that case you presented is a great patient where you discuss with the patient the pros and cons.
So just one word on aspirin and VTE prophylaxis.
Mm-hmm. I know nothing about VTE prophylaxis, so I'm not
There
even.
you go. Okay. Ted, well, thanks. That was great. And hope to see you around, and stay well.
Thank you. You too. Take care, guys.
Okay, thanks. Bye now.
Bye-bye.